Welcome to Ethnic Media Services Briefing, co-sponsored by the California Department of Public Health's Vaccinate All 58 campaign. Thank you all for joining. I'm Sandy Close, EMS Director, and today's moderator. The COVID-19 pandemic, its disproportionate impact on specific groups, and questions about disparities in healthcare access have dominated many of our briefings. We believed it was important to focus this pandemic briefing for 2022 on the group that, the group whose work is among the most essential to society's well-being, but that is also largely invisible. Those in California's agricultural industry, the #1 producer of food in the United States. More than 800,000 people work on California's farms and at its packing facilities. They produce almost 2/3 of the nation's fruit and nut supply and about 1/3 of its vegetables. 18% of all dairy products consumed in the United States and 3/4 of all medium grain rice. Yet these essential workers have been and remain among those at highest risk for COVID-19 and face ongoing challenges in accessing health care. Today's speakers will share the latest data on COVID's impact on agricultural workers, how they're faring under the current triple endemic, and state and local initiatives to expand their access to vaccines, to boosters, and to antiviral treatments. Speakers will also explore healthcare challenges in the year ahead amidst an ongoing drought. Our speakers include Dr. Ilan Shapiro, Chief Health Correspondent and Medical Affairs Officer at AltaMed, and Arsenio Lopez, Executive Director of the Mixtec Indigenous Organizing, a community organizing project known as MICOP. And now we're pleased to begin with Dr. Ilan Shapiro. We welcome you, Dr. Shapiro, and look forward to an overview from you on the state of health, especially during the pandemic, of our agricultural workforce.
I'm going to, first of all, thank you so much. Even though that my complete experience right now for the past 7 years has been in AltaMed from LA County to Orange County, serving more than 400,000 patients, I worked in Fort Myers, Florida, that I was serving a lot of migrant workers. And the reality is that we have had really good moments during the pandemic and some things that we need to continue making sure that we can fix and improve for the health of our communities. The first thing is that the way that we delivered healthcare in 2019, from education, communication, and of course, all the campaigns that we were doing were quite different. We knew that going to, to our farm workers was essential and important, but we never felt that until we were struggling in 2020. When most of the communities were at home, they were out there making sure that we had opportunities to have something to feed our families, and they were getting exposed and also, working as an essential worker for our community. Right now, the things and take-home messages that I take at this moment is, how can we better communicate? I do not talk about education. Education, it could be a degree, MBA, a doctorate level thing. Right now, our communities need information. And how are we going to deliver that information? We have seen in California we actually put a lot of coverage out there from radio when they were working to actually going out there and talking one by one to make sure that they understood the importance of, being protected, being there for their families, and having that equal opportunity to treatments and preventive services. Then COVID-19 right now opened a lot of conversations for our communities, from farm workers and other essential workers, to the point that now we know that we need to start putting concordant doctors in areas that, our communities needed. When we went to the fields, when we go out there and do the campaigns, and they hear me speaking Spanish, or actually we can bring some other indigenous languages, they smile. And maybe I do not understand Quechua or other languages out there, but at the moment that we are there and we try to mix and match the best way that we can, that actually serves the community. Because the cultural aspect of, herbs, of medications, and other things are essential part of how are we delivering care in our fields for that specific community. COVID-19 hurt our community. We know that at the moment that they live in certain close quarter areas, the possibilities of getting infected were higher. And not only that, the complication rate when you have diabetes, hypertension, that a lot of our community actually has, it creates more waves and problems. And I take right now, and then I'm going to switch a little bit to the story of the campaign that Altamed did with Andale Que Esperas, and we were actually partnering also with Vaccinate 58. We were out there and making sure that we were creating content in a fun and informative way. That way we can actually share it via WhatsApp, via social media, and most importantly, having that one-to-one conversations. Then that's the key here. The problem is not that we do not have resources. The problem is how are we going to use the things that we know right now? Because we had from 2020 until 2022 to learn a lot about COVID-19. And of course, the importance of making sure that the gaps for social determinants of health are closed. When we have both of them, that's the moment that our communities, farm workers, their kids and families get better. Because the vaccine, it's not against COVID-19. That vaccine is against injustice. That vaccine is against a lot of other things that we have around our community. Then right now we need to bring more vaccines to our communities. Health, wellness, mental health, because being there is a struggle and it's hard. Recognizing the things that we have and making sure that we are helping our community leaders. And a shout out for all the promotores and promotoras de salud, for all the community health workers that were there on the fields, and they were doing amazing job. Me as a doctor, I can tell you for sure that I can, even if you give me all the money of the world, all the hospitals, all the doctors, I can just change 20% of the healthcare wellness of someone. That 80% depends on information and the things that happen literally where they live. Then that's why creating this type of conversations, highlighting the opportunities that we have. It could be technology. It could be our amazing promotores and promotoras, our community health workers. We need to choose and make sure that we do not roll back to 2019. It's essential for our community, and it's essential for the entire country to make sure that our farm workers are healthy, taken care of. And if it's COVID-19, influenza, diabetes, hypertension, any of these things that we are struggling with need to be accounted for and the resources given. Because how essential is oxygen? How essential is our food? How essential is to be together with the family? Thank you.
Thank you, Dr. Shapiro. Could I ask one quick follow-up question? You are someone who is based in Los Angeles, so you have a strong sense of COVID's impact on urban dwellers as well as rural and agricultural workers. How would you compare to how would you describe the vulnerability of farm workers to the pandemic and the infection rate that farm workers experienced compared to urban immigrant populations?
We do have limited data, but the stuff that I have read, and you compare the possibilities of getting infected at the moment that you're co-living with more people, you're working, the only advantages that they were having, they were actually living on an, working in an open field. And at least that creates a little bit of shelter, but they were coming back to, quarters with a lot of people sharing a lot of things, and the exposure was real and it was there. There was no, idea of, take your space, take your time, take yours. And a lot of the times, because of disinformation and misinformation, a lot of the conversations were hard and very difficult. And a lot of them actually suffered, not because of, not the ability of having the vaccines, but not the ability of having a conversation with someone that would understand where they were coming from. And what was the real question about being harmed, about, what if I cannot work, I cannot, produce for my family. Then there were a lot of things that were not accounted for in rural areas that I hope that we start changing that.
You referenced the lack of doctors in rural communities. This is one question that comes through the chat that I'll ask before we move on to our second speaker. Do you think the number of doctors in rural communities or the number of clinics has increased as a result of the pandemic, or have people trained themselves to become community healthcare workers to help fill the void, or both?
The thing that we have in California is that a lot of the times we do not have concordant doctors. What do I mean with this? That, usually, and there's a lot of literature regarding this, when you have a doctor that speaks your language or understands your language or your culture, you can actually have better impact on outcomes of diabetes, hypertension, and other things around this. Then, sadly, right now we have seen a huge amount of doctors, nurses, and just health workers that chose to actually leave the field of medicine. Then California is actually suffering. We do have a lack of doctors, nurses, and healthcare workers. Then this was amplified during COVID-19, burnout, and a lot of other factors. Then my true answer is that, I would love California to produce more doctors in the UC system. I would love to actually have more rural programs there. In Mexico, we have something called social service, where part of your training from the 6 years to become a doctor, 1 year you actually go to places of need and actually to help out the community. And probably programs like that can benefit long-term efficiency of the things that we're doing. And also, bringing those kids that want to be doctors on the area. There's a lot of rural kids that, worked on the fields and they are ready to go out there and be doctors. And how can we amplify that? And of course, we need to give the tools to our proud promotores y promotoras, our community health workers, because they have been achieving a lot of things that traditional medicine, to call it a way, has not been able to communicate with our people in the fields.
Thank you so much. And please stay, because there are a lot of questions. And I look forward to having your comments. Our next speaker is Arsenio Lopez, Executive Director of the Mixtec Indigenous Community Organizing Project, for a really close-up look at the impact of COVID on Indigenous farm workers in Ventura and specifically Oxnard. Mr. Lopez, thank you for joining.
Sandy and others, thank you for the invite. It's my pleasure to be here with you all. Um, I think it's already kind of mentioned it that farm workers were one of those big the communities that were mostly they had a big impact during COVID. We just focused a little bit more into the indigenous farm workers communities. I think our organization for the last 20 years that we are in Ventura County, we're doing a lot of efforts on making sure that there are more awareness of the diversity that exists within our own communities, within the Mexican migrant communities, that we all not speak only Spanish, that we speak our own indigenous native languages. And the state of California, within the indigenous migrant communities, farm workers, I will say Mixtecos is one of the larger indigenous communities, but also we have other indigenous communities that they speak their unique language way different from Mixteco or Spanish. And I think when we had this unfortunate situation of COVID, at least what we saw numbers one issue for these communities was and continues to be language access. Unfortunately, still we don't see the health system being ready to provide service, to be able to provide services in the linguistically and culturally manners to farm worker communities. I think that we have to move away from only, which is perfect to continue advocating for more Spanish speaking providers, but we also need to be continue having conversation, which we already started a conversation on how do we create system change at a system level that will enable these agencies to be able to serve communities that they don't speak Spanish or English, that they speak other languages. Our organization, I think, during the COVID, which was crucial on doing the outreach and education, was working with promotoras, as already been mentioned. But I think that is not just about working with promotoras, but I think it's giving the important values that promotoras has. I think one of the things we saw is that it's being more flexibility, or it's being more like willingness from the system of healthcare agencies to be able to work with community-based organizations who has promotoras model and be able to, there's conversations on how the promotoras have been a champions on bringing this information and creating access for those hard to reach, underserved communities members to be able to navigate the health system. And I think that's one of the other thing that we would like to continue doing because of what is already mentioned as, for example, the expansion of medical benefits. There might be some kind of opportunities that will provide access to these communities, health access, but if our communities, they don't know about the navigation of those benefits, then it will be almost impossible for our communities to take those opportunities or advantage of those opportunities. And I think promotoras can be those bridge. One of the things that I think that we also started being more aware and worry about the farm worker communities is about the mental health situations that our communities have right now as a consequence of going through all these almost already 3 years of COVID. Many of our farm worker families lost their families, their members or their loved ones. And there's a lot of increase on anxiety, stress. And I think one of the things that I can remember from the stories hearing from farm worker is the mistrust that our communities has with the health system. And there was a lot of miscommunications when COVID was happening. There was a lot of doubts when farm workers were, they got COVID, if they should go and be hospitalized or not, because it was as part of the miscommunication or messages that they were getting. They were feeling that based on what they were seeing from other families, is that once they were ended in the hospital, it was for sure they died. Versus those that stay home and taking home remedies for COVID, like tea or any of that, they survive. So I don't know if that's consequence. I think my point is that historically, there's been a lot of mistrust between, in our case, indigenous communities, farm worker communities to the Western health, that we need to be aware on how can we continue doing more intentional work on building that trust with our communities. And I think that mistrust or that trust get more impacted when our community is trying to have access to the system and their experience are not being positive. They get there and they are not being provided the services in the language that they speak. And that's where I say that language plays a very crucial role into reaching out or providing services to our communities. I remember that in 2019, 2020, one of the big challenges we were having is about public charge. We had to remember, or we had to know that within farm worker communities, indigenous communities, farm workers, at least 60% lacks of immigration legal status. And when they were saying a lot about the public charge, many of our communities members didn't want to believe us as leaders or as a community organization telling them there will not be public charge. It takes a lot of work to get our people to trust that there will not be a big bill that they will come to their homes if they go to see a doctor. Lastly, I think I would like to just mention it about the complexity of farm workers, populations, or communities. I remember that we were talking about H2A workers. H2A workers is a specific sector of the farm worker population that is almost impossible to reach because we don't know where they are. They're very mobile. They might be here in Oxnard for a week, and they might be moved to up north California next week. And they also like these type of like programs makes workers very vulnerable because they might be here for temporary for months. They might got COVID, and we don't know what the consequence on that were because the next and like in 3 months you will not see those workers because they went back to Mexico. And there's a lot of like challenge there in terms with these type of workers, because there were some of them that they know, and there is that narrative that happens within the workers that if they complain, if they say something, that the next time they will not be recruited to come back to work in California. So there's a lot of vulnerability there as well. We're talking about H2A workers, indigenous farm workers, and other workers. So we have to be thinking and having conversations on how, when we're designing programs about outreach, educations, that gets combined with language, gets combined with a type of a sector or group of workers that we're gonna be bringing this outreach. And also, once the education and outreach, once you get that workers to agree to go and see a doctor, that when they get in the front office, that they the clinic or the hospital are able to identify if the workers that don't speak Spanish, that if they speak Mixteco or if they speak Zapotecos, that they will be able to provide those interpretations. Because in our experience, sometimes is that all the work is being done and the workers get to the hospital, to the clinic, but then there is no language access. And it's when the workers will return with no service. So I will just stop there.
Thank you. Could you tell us just briefly what the state of health in this winter triple endemic, RSV, flu, and COVID? Are you seeing a lot of the people who work in your indigenous communities getting sick? Do you sense an increase, or are things pretty stable, no big increase or decrease. What would you say is the state right now for farm workers in Oxnard?
I don't like to say this, but I think I'm worried that we're getting to that phase of making this whole thing normalized, as a way it happens with flu. Definitely, we have seen farm workers getting positive with COVID. But I think my sense is that there is not this feeling of urgency that these cases are being increased, because right now the recommendation, you get sick, just stay home, seek for treatment, make sure you get your vaccine. There's also like farm workers getting COVID testing for home, take COVID testing. So I think that's contributing to like helping, but I definitely see an increase of COVID right now in our communities. My worries though is that I think the sense or the feeling is there's not urgency as it was previously.
Right.
But definitely there's an increase on positive cases.
Hey, thank you. You've really underscored for all of us the extraordinary importance of communication, of test to treat, of the gaps that remain, and as Arsenio put it, the danger of normalizing COVID as if somehow we've moved past, whereas we clearly haven't. Thank you so much. Look forward to continuing these communications with you. Thank you.